Hello, and welcome to the Practicing Clinicians Exchange podcast. I'm your host, Dania Reynolds. Today's episode features experts in pulmonary and critical care medicine answering audience questions from a live virtual Q&A webinar titled Evidence and Guidelines for COVID-19 in Hospital Management, Putting It All Together. During this podcast, Dr. Vikram Mukherjee and Cameron Smith will answer the questions that cover important topics, including management of viral co-infections, such as influenza or RSV, new data comparing baricitinib and tocilizumab for patients with severe COVID-19, how to approach bacterial and fungal co-infection while incorporating antimicrobial stewardship, and tips for transitioning patients out of the ICU into the medical floor or to home. For more information on Dr. Mukherjee and Ms. Smith, along with a link to the complete program, including the accredited webcast, please visit the show notes. Now let's get started and hear what the experts have to say on this important topic. Joining us today are our expert faculty members. Dr. Vikram Mukherjee is an assistant professor in the Division of Pulmonary, Critical Care, and Sleep Medicine at the New York University School of Medicine. He also serves as the director of the Medical Intensive Care Unit at Bellevue Hospital in New York. Cameron Smith is the lead advanced practice provider in the medical ICU at Bellevue Hospital as well. And we really wanted to thank both of them for being here with us today. But I think unique with this COVID surge in particular, or this particular season compared to previous years, we've seen more co-infections with influenza, which were down due to measures like masking and social distancing, but now we've seen sort of resurgence of the flu. So Vikram and Cameron, in your experience, how do you handle those patients differently? And have you seen patients that have co-infections with COVID-19 and the flu?
Yes, you're right that this season, as social distancing and masking rates have continued to drop, we are seeing, especially in our ICUs and in our inpatient units, a fair number of co-infections, not just influenza plus COVID, but RSV plus COVID, RSV plus influenza, the other adenoviruses that come with. And, some of these patients can get pretty sick. The signal of whether these patients are sicker than a monoinfection is still out there. We haven't seen a worse severity of disease if patients have two different viruses than compared to one. But we do have to make sure about two things. One is just because you found someone with COVID who's tested positive in your ICU or on your med-surg floors doesn't mean that you don't look for other more seasonal viruses, such as the ones we just mentioned. And B, you should think about the countermeasures. For example, for the influenza the infections, you should think about the Tamiflu or certain medications if the patient meets criteria for them. I guess the take-home point is just because someone's coming in and looks like COVID, which all of us have seen in large numbers over the last 3 years, also keep in the back of your mind that this could also be a co-infection with the adenoviruses, with the rhinoviruses, with the RSVs, and so on. Cam, over to you.
I have to agree with Vikram on this one, everything he said regarding co-infections. We've seen quite a bit of flu this year, and especially RSV. And sometimes it's hard to differentiate respiratory symptoms, which respiratory virus is creating which problem. But for most of our patients, they're incidental COVID now because they've received vaccines, both doses of the vaccine in most cases, and have been boosted twice. And so what we're seeing is they just happen to have COVID because it was tested on the respiratory viral panel. But the actual culprit of what's causing their issues might be RSV or flu, which I think we've treated enough to know how to handle that.
Let's say you've sort of maximized those non-pharmacologic therapies, but you still have a patient who has worsening oxygen requirements and is already on dexamethasone. And you start to think about some of those other adjunctive therapies, modulating therapies like tocilizumab or baricitinib. What factors do you take into consideration when deciding between those agents? And do you have any pearls of wisdom for formulary management of some of these newer therapies as they come out?
Great question, Dania. There was an article that just came out, published in the Society of Critical Care Medicine for March of this year. And it was a retrospective and observational cohort study. And it discussed the outcomes and effects of baricitinib versus tocilizumab in the management of severe COVID. COVID-19. Before this, we hadn't really seen many larger scale studies that were published comparing the two agents. They did this study at 11 hospitals or 11 acute care centers that were part of a larger hospital system and ended up getting, I want to say, around 580 patients into two different groups, one receiving bari, one receiving toci. And they didn't see any difference in mortality necessarily, but the occurrence of adverse effects was significantly higher in patients who received toci, whereas compared with baricitinib. And these adverse outcomes we're talking about can be secondary infections, it can be thrombotic events, it can be acute liver injury. So these are things they looked at in the studies, and they found in all of these three adverse outcomes that people who received toci had a higher outcome of adverse effects. I'd have to say, going by this study, which was, again, it's an observational retrospective cohort study, not a blind study, not a meta-analysis. So knowing all of those things, it looks like bari may be the better option to decrease adverse events. That's what we learned from that.
Thanks, Ken. That's a really nice review of very recent literature. As you heard, this came out less than a week ago, and it's out in the March 23 journal. I would also echo Ken's thought that at this point, we are adding a second very strong immunomodulator. So you have steroids on board and you're adding a very strong immunosuppressant such as toci or bari, whichever your hospital has on formulary. So you do want to keep an eye out for infections. You're immunomodulating your host system to such a large extent, you're making the patient fairly prone to bacterial infections, CLABSIs, CAUTIs, ventilator-associated pneumonias, and then, of course, some fungal infections as well. So yes, be very wary about the side effect profile that Ken just described so elegantly among the two drugs, but also keep in mind, whichever one you use, both put your patient at a fairly high risk of opportunistic infections in the ICU, fungal and bacterial both.
Thank you. And I did want to circle back on this secondary infections question. So these patients with COVID-19 are in a hyperinflammatory state. And so they do present sometimes septic and they look really sick. And I think it's hard not to treat them for bacterial infections. But hopefully many in our audience saw some of the CDC data that came out towards the end of last year that had some striking numbers about the increase in antibiotic use, particularly in the inpatient setting, and a corresponding increase in the rate of multi-drug resistant organisms, some scary ones like CRE and multi-drug resistant Pseudomonas and Acinetobacter. So how do you differentiate between COVID-19 and other bacterial and fungal infections so that you can really maximize antibiotic stewardship and really only use antibiotics when you absolutely need them?
Yeah, thanks for that question, Dania. The true answer is you don't know until you investigate it. It's tough to be in a hospital and see those pop-ups that say your patient has flagged for sepsis because you immediately want to start them on, give them fluids at 30 milliliters per kilogram and get cultures and then start them on broad spectrum antibiotics. But that's not necessarily the answer with COVID. With COVID-19, we talked, if you've seen our presentation, dry lung is a happy lung. You don't want to overwhelm these patients with fluids unless, of course, there's like severe blood loss or hypotension or poor tissue perfusion with a high lactate. So, that's something that's different from our sepsis protocol. And then cultures, absolutely. We get urine cultures, we get sputum cultures, we get blood cultures. We want to test everything we can to ensure there's not a superimposed infection. But most of the time, this tachycardia, this tachypnea, this fever is just COVID alone. And we want to investigate that. If we think there is a high suspicion for a bacterial infection, then yes, we may start antibiotics. But most of the patients that come to us from home, they don't have a bacterial infection. It's just a viral infection. You can't treat viruses with antibiotics. We want to be good antibiotic stewardships because, Daniel, you're right. There are so many superbugs out there. And we have patients that come into us that are already immunocompromised with AIDS, with cancer, who can't defend themselves against these bugs. And so we've got to be great antibiotic stewards for everyone.
Absolutely, Cam. I'm sure that the CDC report is a consequence of all the antibiotics that were thrown at COVID pneumonia patients in the first 6 months of this disease. And of course, that wasn't the wrong thing to do. The data was still very nascent. There was the fog of war, which made things, it's difficult not to start antibiotics in a patient who's dying in front of you of a pneumonia. But the numbers are pretty clear now around in patients who are coming fresh into your hospital with, a week of symptoms and disease onset. The number of times you'll actually have a bacterial infection in a new onset COVID patients is less than 2 to 3%. So unless you find good culture data, you should be okay just treating with antivirals and steroids and the always supportive care we just mentioned. That said, phase 2, the patient's been on the ventilator for a week. The acute phase has kind of diminished, but now on day 10, the patient has a new pneumonia, a new fever, worsening secretions. If you culture them then your risk of finding a bacterial infection is much higher. And at that point, you should have a much lower threshold to start appropriate antibiotics. But like Cam and Daniel mentioning, fresh COVID coming to you with acute viral pneumonia, there really is a very small role for antibiotics to play.
Do you have any tips for how to transition these patients out of the ICU and also out of the hospital? So these patients are on many medications and have many transitions of care items that need to be taken care of to reduce the risk of medication-related errors and make sure that patients are queued up for discharge. So any tips that you found useful when getting patients out of the ICU and the hospital?
Great question, Dania. We work mostly in ICU, so we'll talk about that, the transition from an ICU to a non-ICU setting. And you're right, that sometimes the ICU course can be so stormy. Even if the patient survives the ICU stay, making sure that the patient transitions to an appropriate level of care with no interruptions in management from one phase to the other is absolutely crucial to making sure that the patient has somewhat of a recovery. And to be honest, the interventions that we often offer in the ICU can have long-standing consequences. For example, the paralytics that we often are compelled to use lead to muscle weakness. The sedation that we are often compelled to use lead to delirium and cognitive dysfunction. So there's a huge role to play in two ways. One is making sure that once the patient goes to the floor, from an ICU setting to the floor or to a long-term acute care facility or to a nursing home, there is an absolute seamless transition of care. The antihypertensives don't fall off. The insulin regimen doesn't fall off. The antibiotics are completed and stopped at a particular date and so on. And B, there is a solid post-ICU clinic for patients with COVID, making sure that physical therapy is working with them to get their muscles back in order, to making sure that psychologists and behavioral specialists are dealing with the delirium and the PTSD that comes with a prolonged ICU stay. And also, very importantly, making sure that the family of the ICU patient is just as well taken care of, because as you can imagine, there's a lot of stress and strain and anxiety in the family members. Of course, the patient is the key, but the family usually plays, as you can imagine, a significant role in the recovery process. So great question, Dania. Thank you. Back to you, Ken.
Oh, Vikram, I think you said it perfectly. And that was what I wanted to also reiterate, was that you're not just treating the patient, you're treating the family. We have a lot of families who care very much about their loved ones, and it's a long journey ahead once they leave the ICU, even once they leave the hospital. And it is important to provide them with all of the resources that Vikram mentioned earlier. We don't know the full repercussions of long COVID, but we can have long COVID whether you get it and have no symptoms or whether you've been intubated in the ICU. And knowing that there's a long road ahead, but there can be recovery, is a very important thing to let our patients and their families know.
Thank you very much to Dr. Mukherjee and Ms. Smith, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, evidence and guidelines for COVID-19 in hospital management, putting it all together, and view the accredited webcasts associated with this discussion from the Practicing Clinicians Exchange website, please visit the show notes. As always, thank you for listening.